Hey, it's me, Jen again. And you may remember a previous interview I did with Dr. Kathleen Hands of San Antonio, Texas. Well, today we're catching up with her again, and she's telling us more about what's going on in the world of thyroid RFA. Coming up. Today's guest is Dr. Kathleen Hands of San Antonio, Texas, and she's very passionate about thyroid RFA and preserving the thyroid whenever possible. She's going to tell us more about what's going on in this area of medicine and why she thinks that soon this will be the standard of care for treating thyroid nodules. Let's hear from Dr. Kathleen Hands.
Really is amazing. The things that I'm seeing that are just, it's kind of sad because patients have let themselves go to the point where they have such little confidence, I think, in the medical profession that they're not taking care of themselves. I had one come in Wednesday, a week ago, 20 centimeters. She absolutely has avoided surgery for 10 years. You just look at this thing and you say, it's going to take at least 4 sessions. And just because I can, doesn't mean I should. And my greatest concern for this poor girl is, if I don't do it, somebody else is going to do it. And shouldn't. They really shouldn't. This is somebody who absolutely needs to go to surgery. She has an airway that's smaller than my pinky.
Oh my goodness.
She's crushing her airway. And I think she has zero margin of error when it comes to swelling. And it's just her right lobe. Her left lobe is pristine. She may still be able to avoid medication. Everyone thinks that they're a candidate now. And if you have this tool in your hand, you think every nodule is a candidate as well. And I think that's one of the hardest things to convey to others who were trying to get involved with this procedure as to who really is not a candidate just as much as who is a candidate.
Right.
It's been a real learning curve to see what's out there over the past year.
I think a lot of patients have been waiting for this to become available.
Absolutely.
And some of them are just so desperate to see if they're a candidate because they're doing everything they can to avoid surgery. A lot of them have tried natural remedies. I cannot tell you, Dr. Hands, how many people ask me, what can I do naturally? What supplements can I take? What diet can I try? And I always tell them, there's no one standard thing that works for everybody. There's some people who say, oh, I tried this and it helped. And other people say, oh, I tried that and it didn't work. There's nothing standard out there. There's no research to back it up. So many people are desperate. I think that the biggest problem, talking about what you were saying, is that there are so many doctors who are not trained in this, who just immediately dismiss it as, oh, that's a terrible idea. Don't go for that. And so a lot of patients have already prepared themselves. I'm going to meet resistance with this. I think it's a good idea to get multiple opinions. But a lot of them may be thinking, I need to get all these opinions and I'm going to keep asking until someone says yes.
Right. My surgeon I use almost exclusively for thyroid cancer surgery. I mean, he's a head and neck cancer surgeon. He's amazing. Mm-hmm. He is coming to observe next month the procedure being done. Mm-hmm. And he's totally into it. He understands that if he's not doing this and offering patients another viable alternative to whopping out their thyroids and having to go through surgery and be on medications the rest of their life, he gets it. He understands it. And he wants to be able to provide what should actually be the standard of care.
Right.
What we're finding is that because, this was approved shortly before, the whole COVID epidemic started, that we have not been able to do our generalized meetings at the American Thyroid Association, the Endocrine Society, the American Academy of Clinical Endocrinologists. All the meetings were taken away. And so all of the education that would have taken place for the surgicals, for the radiology, for the other endocrinologists, and even for the PCPs, because the first thing a PCP does when they get the ultrasound is send them to the surgeon.
Right.
And the surgeons are going to cut. That's what they do.
Yep.
So really trying to educate more of the surgeons because we want them to be on board. And quite honestly, over the next 5 years, the surgeons that aren't doing it, they're going to find themselves obsolete in the realm of thyroid nodule care if they're not on board with this. And they have a much larger training curve than an endocrinologist simply because they're used to hands-on in the neck dealing with the actual anatomy as opposed to 3D images that you're getting using a patient, looking at a monitor, using your hand somewhere else. That coordination is totally foreign to them.
Yeah.
And so the learning curve for them is a little greater. And so we take a lot of care when we're training surgeons over what we're going to do with endocrinologists or even radiologists because they're very doing those things. So it's been a real year of learning curves in terms of how do we go about training the right people to do this.
That's very interesting. I'm really glad that you mentioned that. Yeah, I'm hopeful that maybe as we're kind of inching toward being back to normal in the world, that maybe that's going to start to resume that path that it was already on before the pandemic. Do you see that happening?
Oh, I sure hope so. I'm fearful that this is like the new norm.
The pandemic, you mean?
Yeah, there are still a lot of doctors that are not hands-on with patients, that they're still doing telemedicine and they're not actually examining patients. And I can tell you the last probably 6 months, all the patients that have come to see me had studies done for other reasons. They had no idea they had a nodule and they didn't know what to do because no one's seeing them. So they're all doing their own research. There's a couple of surgeons from around the state who have absolutely referred, but the bulk of them are patients who are doing their own research because their primary care doctor just tells them, you need to go see an endocrinologist, you need to go see a surgeon, and they don't know what to expect. They haven't been evaluated. They don't know if it's cancer, if it's not cancer.
Right.
So they're desperate in a sense because
Yes.
they really don't have they haven't gone through that process that we normally would have done to get them to the point where you would even recommend RFA. It's been a whole different form of practicing medicine through this pandemic. And I really see the pitfalls of where we've gone this year. And I can only pray that it improves dramatically over the next couple of months, because I really thought this would be over months ago. Everybody would be back to some form of normal in their own practices, but even a lot of physicians are still not comfortable seeing patients, which I think is unfortunate.
I agree, Dr. Hands. I think that in general, patients who have thyroid nodules are very fearful because there is a lack of education out there about what a thyroid nodule is and what the statistics say about how often it's cancer. And so I can't tell you how frequently I get Facebook messages or Instagram messages or YouTube comments from people worldwide saying,
Right.
I just found out I have a thyroid nodule. Does it mean I'm going to die?
Oh boy. So
I'm serious. That's very common.
one thing you can do right from the get-go, and it's pretty standard, I think most endocrinologists would stand behind the facts and saying, every nodule. So if you have one nodule, if you have 5 nodules, it doesn't matter. Every has a 10% risk of malignancy, which means there's a 90% risk. It's nothing.
Right.
So you do the biopsy if we think it's suspicious. And people think that, old school was you biopsy the largest nodule. And that's not necessarily the case. You biopsy the nodule that is suspicious. You have to look at the features of the nodule. And this is something, you can put on your website. If it's hypoechoic and it's got high-grade vascularity or calcifications, its borders are ugly. There's a lot of features that we look at. Oftentimes they come in and they have their own ultrasound and it says the nodule is 3.2 centimeters. Okay. And
Right.
and so they have no idea what they're coming in with. So I educate them about what it is, and I tell them, now this is a spongiform nodule that has less than a 1% risk of malignancy. It doesn't matter that it's 3 centimeters. I mean, you really have this very benign process going on, and they always walk out of the office, of course, reassured and know that they're not in trouble. We biopsy the ones that we think need to be biopsied. We certainly do that before RFA because we want to make sure that we're not dealing with any underlying malignancy. But most of the time you can tell by ultrasound, if it's done correctly with all of the features notated for each nodule, that they have a benign process going on. And the other thing to help them understand is they'll say, oh, I had a biopsy 3 years ago, but they told me it turns into cancer. They do not turn into cancer. That is a
Right.
myth. There may be a foci within that nodule that might be malignant, but the nodule itself does not turn into a cancer. And so evaluating the neck for lymph nodes, evaluating the whole neck, not just the thyroid, which is what happens on a standard radiologic ultrasound. They just examine the thyroid. They don't ever comment about what else is going on in the neck. Unless you're looking at all of the structures in the neck, you miss those little nuances. Are there unusual looking, suspicious looking lymph nodes lateral to this nodule? When you're doing a proper evaluation, that patient should leave your office after getting that ultrasound and know that they do not have a high risk of malignancy. And even if they did, they have a 98% survival rate at 20 years.
Mm-hmm.
Nobody dies from thyroid cancer. The 2% that die from thyroid cancer, we know when they walk in the room. These are ugly, invasive tumors.
Mm-hmm.
And that's less than 1% of the patients that walk into my office that have thyroid cancer. Less than 1%.
Wow.
And yet everybody believes that they're going to have, they get the big C. Right now, the push, very importantly, from the American Thyroid Association, we should not even call thyroid cancers that are less than 1 centimeter, the typical papillaries. We should probably stop calling them cancers. We can watch them, we can observe them.
Mm-hmm.
And the push, the standard for today is to observe these small, inconsequential cancers. If you look at the data worldwide, you'll find that 34% on autopsy have thyroid cancer, didn't know they had it. 34%. That's a pretty high statistic. So when you think of the terms of, what this cancer does and how aggressive, it's an indolent cancer in a 99%. It's totally indolent, very slow growing, and they don't do anything. It's the only cancer that can go to the lymph nodes, metastasize all over the lymph nodes in the neck, and still be considered stage 1.
Wow.
When you help people understand those basic facts,
Yeah.
it helps them. You're trying to alleviate fear, as we should, and be reassuring to them that these less than 1 centimeter cancers don't even need to go to surgery anymore. Getting that word out, again, then that's the big ploy too, because these conferences have all been canceled.
Right.
Getting the word out to people, to endocrinologists, to surgeons, to the people that treat these individuals with small cancers. That's been a problem. And now we really do consider it more the standard to observe those patients. If they don't have any suspicious lymph nodes, they don't have any suspicious features other than a positive biopsy less than 1 centimeter, let's watch it. Let's see what happens. I had a patient, she had a 2 centimeter, probably about a 35-40% risk of cancer based on features on the right side. And on her left side, she had a 9 millimeter lesion, which I didn't really want to biopsy. Don't do that typically. If that was all she had in her neck, I would tell her we're not going to biopsy. But because we were biopsying the other side, she said, look, we're in there. Let's just do it. We do it. It turns out to be a papillary. So now we're stuck with this 9 millimeter. And unfortunately, this patient has a form of muscular dystrophy in her throat, which gives her very difficult swallowing and phonation at this point. Her mother had the same condition. It's almost 100% penetrance in the genetics. This is a person who, God forbid, has any complication with surgery, will be significantly impaired, as opposed to whopping out a 9 millimeter papillary thyroid cancer that was probably never going to harm her or do anything to her. You really have to pull back and you have that discussion with the team, the primary care doctor, the neurologist who's treating her, the surgical consult, because they all have to kind of be on board with the same thing. When you're looking at risk versus benefits, we need to just pull back and say, you know what, this 9 millimeter cancer is never going to cause any difficulty to this 60-year-old woman who's already got an underlying neurologic condition, which is more than likely going to shorten her life significantly already. So adding something just for the sake of doing it in something that's so indolent, that's the word we need to get out to individuals, that we are in a place now where we're actively saying, let's observe these small cancers and stop whopping them out. Ultrasound is a great tool. You can look at it in 6 months, in a year, in 2 years. If it's stable in its growth pattern and it's not doing anything, you're fine. Maybe we can buy 5 years. Maybe we can buy 10 years. Maybe you'll never have to have surgery at all, and you'll maintain your normal thyroid function. We're talking the same thing now with the RFA, right? We can fry this nodule, and you're going to maintain normal thyroid function. And one of the things that came up also was how does it appear? When I do RFA, I ask patients to come back at 1, 3, and 6 months. And a lot of the patients are coming from a long distance away. And I know it's been difficult for them, but we're trying to gather efficacy data and safety data so that we can try and get this pushed through the insurance companies so that they're on board with this as well.
Right.
So, patients have agreed, to do this. And it is arduous for them to have to come back at 1 month and 3 months. But at the same token, they're getting these images, because all of my patients, they get video of their actual procedure, what it looks like before and after. We go through that with them. They see it at 1 month, they get their measurements. So they can actually see that they're getting a 50% reduction at 1 month. Most of the time, they're getting about an 82% reduction at 3 months. They're so excited to come back and actually see that.
Yeah.
It does look very different on ultrasound. And if they were to go somewhere else and have it done, it would take a lot of explaining for them to tell the ultrasonographer what it looks like before versus what it looks like now, or if they're seeing this for the first time.
Yes.
Because it turns black. It turns it's a black scar. It's a dead tissue. And if you're just doing ultrasound for the first time, you would look at that and say, oh, it's hypoechoic. And they would raise the suspicion of cancer now in this nodule. And the patient, not knowing, would be, oh my goodness, I did this procedure and I had it, So they have to understand, they have to see what it looks like before and after so they can gather that knowledge themselves, because God forbid they do go get another ultrasound somewhere else. They know what to tell the provider in terms of that's how it's supposed to look. I have an image on my phone that says this is exactly what happened following the RFA. This is a normal image given that I've had RFA. So that's a really good, thing to put out there as well, is helping them understand that it does change the dynamic of what it looks like dramatically, and for them to be aware of it.
I've personally experienced that, and several other members of our Facebook group have experienced the problem of having ultrasounds done remotely and sending them in, and what they hear from the local radiologist or whoever examines them and what they're hearing from their RFA doctor are completely different. And I sat there for a good 15 minutes before my last ultrasound and explained everything in extreme detail, and it still wasn't an adequate ultrasound. It just, and so I'm going, as you were saying before, I'm going to make a trip up to Virginia to get an ultrasound. I live in Alabama, so that's about a 9-hour drive for me. But it's worth it to me to at least have my doctor be able to look at it with his own eyes and say, I know what I did when I treated this nodule. I know how it looked then and I know how it looks now. And to be able to have those percentages and say, your nodule has shrunk by however many percent, and have that clear picture, rather than the not knowing of, do I trust these ultrasounds from these physicians and technicians that don't understand what they're looking at? So.
I think it'd be helpful to tell the individuals that are on your website, when they go, to ask their clinician to give them a picture. Can I take an image with my phone of this? And then they have it, because if they're not going to come back for those ultrasounds, then they can show that image to whoever is doing the radiologic procedure. And it makes everybody accountable. You did this procedure, you spent all this money, you did all this. I want to see that there's results here. I want to see 50% reduction. I want to see that 80% reduction. I have no qualms whatsoever. I have all of my patients, I ask them all, let me have your phone. Let's take some images on, when we're doing the ultrasound. And I think the patients love it. They love to know that the before and after, they're just so thrilled. It's not, sometimes it's not enough that I can swallow now, it's actually see that image. They just beam when they're walking out of the office. I love it.
It's awesome. I always tell patients to take measurements of your neck with a tape measure,
Ah,
because if you've got a sizable nodule, your neck is going to shrink. I mean, mine has shrunk 3 inches in circumference. I
how
mean, three
big
inches.
was yours? How big was yours to begin with?
It's hard for me to remember the dimensions. It was somewhere around 4.5 by 6.5 or 7 centimeters. I know the volume was around 65 to 75 milliliters, so it was pretty
Wow.
large. It was deviating my trachea and esophagus. My airway was compressed by about half. I took measurements of my neck before I had RFA. It was 16 inches, and today it's 13 inches.
Wow. Wow.
So, and I can breathe and swallow and talk and sing. My voice before was lower and raspier. I had a chronic cough. All of these things that I was dealing with are gone.
Right.
So I can identify with what you're saying about how elated patients are, because I know it from personal experience how elated I've been and continue to be over this. It's been an answer to prayer that I was able to have this done. And my goal is to help figure out what can we do, as you were explaining everything about cancer, making that known, allaying these fears that patients have about this. That's the first step. Knowledge is power. And
Right.
getting past that fear. So many patients are afraid to have conversations with their doctor. Just getting past that fear too is huge. And then, finding out, are you a candidate, and do you have access to this procedure? That's the next step after that. So I want to go back and hit on something that you were talking about that I had a question about. You were talking about the cancers being typically very small and slow growing. I've read the statistics on them, and as you said, they tend to be very, very rarely fatal. So when you have someone with a larger nodule, and I hear this a lot, they come to me and they're like, I have this larger nodule. My doctor says there's no way we can know for sure without cutting out my thyroid that this nodule is 100% benign, because you can't biopsy every single cell in that nodule. And I understand that the way that doctors do these biopsies is that you take 2 biopsies, and that the percentages of risk after 2 benign biopsies for cancer, the risk is very, very, very low. And so once you've had those 2 benign biopsies, why is there still this idea with some physicians where it's like, well, we still just can't know because this nodule is 3-4 centimeters?
The real question is, does it matter?
That's what I've been thinking.
Even if the cancer is a centimeter, the standard of care is going to be observation anyway. And so it really is a moot point. And I think the surgeons, are pleading their case for surgery, of course. I don't care if there's a 4 millimeter lesion in there. If the statistics on that is close to like 30% of these big masses will have a microfoci of cancer in it. I tell anybody going to surgery, even though we know it's benign, don't be surprised if on your final pathology they find a 4 millimeter foci. It doesn't matter. Remember what I said, 34% of people on autopsy have it. So obviously, they're dying from a lot of other things, but they're not dying from thyroid cancer.
Right.
I don't care. And it doesn't matter to me that there might be a 4 millimeter foci in there. It doesn't matter. If they have a mass in their neck, right, they're going to have it observed over time regardless. If you do an RFA on it and you get a good result on that, you're probably going to kill it anyway.
Yep.
And now all the data being done in thyroid cancer for these small cancers, it's RFA. This is what they're saying should be the standard of care for these micro cancers anyway. So if you have a subcentimeric cancer, I mean, Mayo Clinic's been doing the data for over 5 years. You've got a lot of institutions out there doing the data. And they were just recently published, as a matter of fact, the safety in doing RFA in these subcentimeric cancers. So it's becoming the standard of care to treat them with RFA anyway. Again, we have to pull back from this idea that every little cancer cell, in breast cancer, that might be true, but not in thyroid cancer.
Right.
This is an indolent cancer. And they really don't even want to call them cancer. The reason it's called cancer is because it has the potential to go from the thyroid to a lymph node. When we talk about cancer here, we're talking about the 99% of the cancers out there that are actually papillary or maybe follicular. We're not talking about medullary. We're not talking about anaplastic. Those are cancers that are handled at places like MD Anderson because they have their genetic forms, their aggressive forms.
Right.
That need to be managed differently. 99% of everything that I've seen in my office has been papillary or follicular. Rarely do I ever see, and you know them when they walk in the door. I mean, these are aggressive looking, nasty cancers.
Mm-hmm.
But we're not talking about those. We're talking about the other two, the papillaries and the folliculars that can be easily managed. The standard is going to be, and it might not be this particular year, and I think it's only because of COVID that it wasn't this year,
Yeah.
but I think within the next year to 2 years, we're going to find that the standard will be either observation or RFA for subcentimeric thyroid cancers and even other cancers. If somebody's not a good surgical candidate
Right.
because they have heart failure or they have some other underlying health condition and anesthesia doesn't want to take them to the OR, RFA is the option, but it takes time.
Yeah.
And that's all I can tell everybody is it takes time. Be patient, go where the experience is, and you'll feel more comfortable.
Mm-hmm.
And like I say, we're trying to train doctors. We're trying to get these programs going. RGS Healthcare with Rudy Garay, I mean, he's phenomenal what he's done in developing these programs for physicians to go to where they can have hands-on models. We've got several stations set up and a cadaver where you can actually do the procedure on a cadaver. It's the only program of its kind, and he does them all over the country. He does these programs everywhere so that doctors have access to these programs so they can get hands-on experience and get the knowledge. Oftentimes they'll come to my office and do observation while we're doing a procedure so they can see the actual tray setup, the surgical setup, the process with the probe, the machine, all of the ancillary stuff that needs to be done. And then I'll go to their offices when they do their first procedure and be there for hands-on if they want something like that, where they just feel like they need a little bit more. I just did one this past weekend in Orlando, and she did great. She did absolutely phenomenal. And now I know she's got the confidence to be able to do that procedure and just give her patients the best possible care for their thyroid nodules. So the more we can get out there, the more we can make physicians comfortable doing this, the better for patients. I've had people ask me, well, why would you have your surgeon come? I mean, he's going to take all your business. That's great. I hope he does. I'd like to retire someday. There's so many nodules out there that, we're going to outnumber surgeons in a long shot. I mean, there's just too many nodules out there, and it's a common problem. People, why did I get this? We don't really know why, but you'll see that it's familial. But the bottom line is there's a lot of these things out there. I think we just need to train more and more people everywhere.
Absolutely. It excites me to hear what you're saying, Dr. Hands, because I cannot tell you how hard it was for me in the beginning to find anything about this online. It was buried. There was tiny amounts of information, and when I did find it, I was overwhelmed by the fact that it was not in layman's terms. And so this is why I do what I do. I want to put this out into the world in layman's terms so that patients understand it, take away their fears. I just want to make this information more easily accessible and understandable by patients.
Help patients overcome this growth in their neck if we can get to them sooner than later, because most of the time for the last 10 years, we've been telling them to wait till it's 4 centimeters before they go to surgery. Now we're saying, gee, you're at 2.5, 3 centimeters, you're at ideal size. Fortunately, a lot of them are greater than 4 centimeters, and that's going to take usually 2 settings. So somebody coming in with a 6 centimeter nodule, that's going to be 2 settings. And, and I explained to them right up front that it's going to take 2 settings, usually 6 months apart, that surgery would be quicker option, that you could be through with this, especially if they have severe symptoms. If it's cosmetic and they just want to get rid of this big mass, they are willing to wait and do it in 2 settings, but you have to be honest with the patient and tell them what to expect and how long it's going to take to resolve the situation. It's expensive. And I've had patients say, well, you should do you should be able to do the second one for free. And they don't understand the cost of the probe, the cost of the surgical setup, the cost of the training, the cost of my staff to be there, the facility
Right.
fee, the anesthesia. I mean, you've got all the different things. Although it's local anesthesia, it takes a lot to be able to do the hydrodissection to get around that nodule. There's a lot involved in this, and we're honest with the patients. We tell them how, I'm going to do as much as I possibly can that first sitting, but sometimes it's up to them in terms of, how much can they tolerate too.
Yeah.
It'll get to the point where they're like, okay, I think I'm done now, and you
Yeah.
have to pick up. Did you get to that point? Did you feel like, oh, I wish they were done, or were you comfortable the entire time? I found that towards about 10 to 15 minutes in that realm, because we're doing it for over an hour, but to localize that probe right where it needs to be takes time, patience, and skill.
Yeah.
And so even though we're in the neck for an hour, we're only doing about 15 minutes on the procedure itself. So, the anesthesia may start to wear off. They may start to become uncomfortable. Did you find that to be the case?
I didn't. In my procedure, I was in an OR setting, and I had a combination of the lidocaine and some conscious sedation.
Okay.
And now I was completely awake. I was completely with it. I remember everything, but I was very comfortable. And I know that when you're training physicians, you want them to understand, this procedure is short, generally takes an hour or less. But in my case, for multiple reasons, my procedures took longer. I had a larger mass, and both of my procedures were done with student doctors observing. So my doctor was explaining everything, which makes it take longer. So both of my procedures from start to finish were 3 hours long. And I know that's unusually long.
Wow.
But I was not uncomfortable. I was actually shocked when they said what time it was at the end of my procedure. So yeah, but I mean, some of that's probably, I was praying that God would take me through that time and it wouldn't be difficult. So, some of that was probably God showing up there. But yeah, I know in the situations I've encountered patients explaining that they only had lidocaine and not the conscious sedation, they have some of them voiced that, after a while, as you said, the lidocaine does start to wear off and they do start to get uncomfortable. You don't want to be in there for hours and hours in just that lidocaine setup. But I know that there's advantages to not having the conscious sedation, and that some people react unexpectedly to that. And so I know there are benefits and drawbacks, and that each patient, is going to have their own individual situation. So I just have one last question that I wanted to ask, and then maybe we can hit some of those questions from the group members. So what words of advice or encouragement to physicians who are considering being trained in this would you offer? What would you say to physicians that are maybe resistant?
Well, you have to find out why they're resistant in the first place. For me, it was, an outlay. It's a big outlay financially to be able to do it. Bottom line is, it's the right thing to do. If you're going to do thyroid nodule care, you're going to call yourself a thyroidologist or someone who takes care of patients with thyroid nodules or thyroid. You should be doing this. That is considered the standard of care. And even if somebody old like me can do it, anybody can do it. Anybody can learn. It's the right thing to do for the patients. And I would encourage them to think about the consequences of what happens when they send people to surgery as opposed to not. Take those things into considerations and the patient's wishes. It's a very individual thing. It's really just got to be a matter of finding the right people who want to do the right thing for the patient.
I love that. It's so common for patients to say, I had my thyroid out and now my life is completely different. And my doctor is completely unsympathetic to that.
Right.
And
right.
I think that's the key is as you said, doctors wanting to do what's best for patients to help them preserve their quality of life. I think maybe that's where the disconnect is. I think there's a lot of patients who have this perspective of me versus my doctor. And I don't want it to be like that.
Right.
You need to work together. And so my goal, aside from allaying fears, is also to just help bridge that gap. Let's find ways that we can have these conversations and work together instead of butting heads. So I like what you said a lot. Okay, I'm gonna pull up the questions that I have in the Facebook group. So this is a question somebody asked. How does a patient start the process of getting RFA? In your particular practice, how does that process look?
What I find is most people have been going to my website and there's information about RFA on there. Sometimes they'll contact me through the website and say, I'm interested in this, what do I do? And I'll just send them an email back saying, call Kate with this number, make sure you have your previous biopsy, your previous ultrasound, your previous labs, whatever you have would be beneficial. We've gotten it streamlined to the point now where if they've already had their biopsy and their ultrasounds, I can basically see them on a Wednesday because most of them are coming from out of town. I can see them on a Wednesday and then do the actual procedure on Thursday. So they're coming overnight anyway. So if they have all their information, we review it all, we go through it all. I've even called patients on the phone to clarify things the week before they're scheduled to come in. So we've pretty much streamlined it to make it easier for them. And, once they've made the decision to do it, they want to get it over with. They don't want to be waiting 2 months for the next available date kind of a thing and getting cold feet or getting the sweats or feeling uncomfortable. I mean, we try to make it easy for them. So in my situation, we have it pretty much down to an art, but we do all the review and stuff beforehand so they can get a sense of what's still necessary. When you come to see me that Wednesday, you haven't had a proper biopsy yet. Your previous biopsy was insufficient material. We're going to need to do another biopsy. And then it takes until the following, Monday to get back those results. So in that situation, we wouldn't be able to do the RFA at the same time. I think docs, again, if they're going to do it, they're going to have to find a way within their own practice to try and train their staff to know what to ask for, what they need to have, so that when you see the patient, you can be prepared, make it easy for the patient. They're already in fear and of the unknown. I think anything we can do to streamline that process is good.
I like that idea of trying to make it less of a burden on the patient because they're already overwhelmed. And if the staff knows what they need to do and then your process is streamlined, then you just, if you can get someone in and then out the next day with their procedure, I can only assume that is just a thrilling experience to, as you said, to get it over with and not have to wait any longer or endure those symptoms any longer than necessary. So that's excellent. So I have a question here. Someone wants to know, why is RFA contraindicated in Graves' disease? Can you explain that?
When you have a gland that is already producing a ton of T3, which is the active hormone, we make T4. We don't really make an abundance of T3. We convert T3 in our liver as we need it. In Graves' disease, you're creating a lot of T3, and it's like speed. You're in there frying that tissue, you are killing tissue and you're releasing preformed hormone right then and there. And so you can put somebody into thyroid storm. So, if they're well controlled on their anti-thyroid medication, and they have a nodule, let's say, that's, obstructing and causing some compression. If they're well controlled on methimazole, they might be okay. But to just treat a Graves patient that's uncontrolled, you have the potential to release that much hormone and put them into storm. So it's not a great idea. These people are already revved up pretty high. So they'd have to be really well controlled. I've done that for 2 patients now where they've been very well controlled. We monitor their TFTs within a week, and then 2 weeks following the procedure, we adjust their methimazole, and they've done fine. It's kind of labor intensive, but you got to be on top of that and make sure that, they don't wind up getting, and we tell them, you start to feel jittery, nervous, insomnia, any of those symptoms coming back, we need to up your dose immediately. So, I mean, they're well educated about what to expect. But again, labor intensive, You might have to get several labs over the month and be available. It's hard to mandate that doctors do that. You just got to want to do the right thing again.
Yeah. I really love that explanation. Is RFA something that can be used for a patient with Hashimoto's and a multinodular goiter?
Absolutely. That's pretty much what we're doing a lot of.
Okay.
The thing to understand with those patients, so Hashimoto's is just an autoimmune thyroid disorder. They're not necessarily hypothyroid in that situation, and that's why you check the antibodies before the RFA. If they have underlying Hashimoto's and they're euthyroid or normal thyroid function, there is a percentage that may go on to have hypothyroidism. So if they're trying to avoid hypothyroidism, you have to let them know that because you have Hashimoto's and we're going to kill off a certain portion of this gland, that may teeter you over into the hypothyroid arena. They'll still have most of their gland that's left behind to function normally, but they may need augmentation now after the RFA.
Mm-hmm.
And that's why you check the antibodies before RFA on anybody, even if they don't have any knowledge of Hashimoto's.
If a nodule biopsy is indeterminate, can you have RFA?
I don't get that many indeterminates. When I do biopsies, they are automatically sent for genetic markers. So if it's a neoplasm, a FLUS, a follicular lesion of undetermined significance, which is now in the indeterminate category, we automatically do the genetic testing. So that's going to reflex into the genetics. So if it's a BRAF positive or PPAR gamma or an HRAS, NRAS mutation, then we avoid RFA and we do observation. If it's BRAF, that's a papillary cancer and they go to surgery. If it's NRAS, HRAS, we will do observation, follow them, see which way they're going to go. They may eventually turn into a papillary. I think the jury's out on that one still. We're not sure whether we should or not at this point.
Mm-hmm.
If we're going to be doing RFAs for cancer, then those will fall into that category eventually.
Mm-hmm.
But for now, if there are no genetic mutations that we see, I go ahead and do the procedure because those are typically lesions that are either just angry and have a little extra changes in them that aren't quite cancers yet. And it may be the standard in the future that these are the ones that are right for RFA anyway. We're starting out, right? In Korea, they've been doing this for 20 years.
Mm-hmm.
But for us, the jury's out and we don't know what the right answers are for that because we haven't had genetics, studies available for FNA just since 2012. So it's only 8 years, and I don't know if they do that in Korea. They're monitoring for that sort of stuff, but there's just no data on those type of nodules. So we're going to have to be the pioneers in saying, okay, what if it is indeterminate? What does it look like? Does it look like it's suspicious? Are there associated lymph nodes in the neck? Is there a family history of thyroid cancer? So again, you have to go through all of those permutations to decide whether or not, the risk and the benefit outweigh one another.
Right.
So I think we just need more time, more data. And, again, we've only been doing it for a year now, so a little over a year now, I guess a year and a half, huh?
Mm-hmm.
So we're just going to have to wait and see. I'm kind of stepping in those waters carefully at this point.
And I think the last question I'm going to ask today is, have you ever seen a patient after RFA who comes in with normal thyroid labs after RFA developed temporary hyperthyroidism?
The thyroid gland is constantly making hormone.
Mm-hmm.
And so you're killing tissue and you're going to release that hormone. So I wouldn't find that unusual. Unfortunately, we're also seeing a lot of this COVID thyroiditis. We're kind of in this time period where we're trying to figure out how much is really thyroid versus viral versus something else. I mean, I've only seen, a handful of decurvained thyroiditis or viral thyroiditis over the last 40 years.
Mm-hmm.
In the last 6 months, I've seen over 20 cases, and they've either had COVID within 3 to 6 months. They've all resolved on their own without any, need for treatment. Now how much is, did that person who had the RFA happened to have COVID 6 months ago. I can see where you would get temporary hyperthyroidism from release of the dead tissue releasing its thyroid hormone, but it's very temporary and it should go away, and they should be TSI negative. The RFA is not going to induce Graves' disease.
Okay, gotcha. People who come in my group and post about you always say, oh, Dr. Hands is fantastic. I love Dr. Hands. And I can tell based on what you're saying to me about how you interact with your patients, it sounds like you've got a really good process worked out. So
yeah.
I'm
Thank you for saying that, because nobody comes and pats you on the back.
no. Well, consider this a virtual pat on the back, Dr. Hands.
Yeah, there you go. Thank you.
You're welcome. Yeah. No, I appreciate what you're doing. I really do. Having gone through several negative experiences with doctors personally, it's so encouraging to me when I get to meet doctors like you, when I get to meet you guys and hear your heart about this. I don't even have the words to describe how amazing that is. To be able to come full circle. It's just wonderful. And I just want you to know you're making a difference in a lot of people's lives, and I thank you for everything you've done.
I certainly appreciate that. Thank you.
Thanks so much for watching. If you found this video helpful, give that thumbs up a big hard hit, and don't forget to subscribe to this channel so you stay in the know. And share this channel with anyone you know, your friends, your family, or maybe even perfect strangers, because you never know who it might just help. It might be the exact information they're looking for, and it could even maybe change their life. And you should do that because it makes you feel good, and it eventually will make the world a better place. Don't you want to do that? I mean, you could go ahead and do that now. The video's over. You're not going to miss anything. Thanks.